I'm here in Naveed. I'm the chair of the Royal Statistical Society Official Statistics section, who've kind of organised and hosted this long-awaited webinar. So very excited to finally hear more about this. So in today's webinar, we will be discussing and introducing the Health Index for England. So Greg Seeley from the ONS will outline the origins of the index, the methodologies used to construct it, and some of its uses. We'll then have Cara Baines and Chris Wilcoxon from Northumbria Healthcare NHS Trust. They'll be explaining how they've used the Health Index for calculating it for an NSOA. And so that will be really, really interesting to see how we kind of see it at a local level. And then then we'll also kind of have an opportunity at the end for a Q&A. So if you have any questions, you can post them into the chat, or you will have opportunity to kind of ask them at the end. So I'd like to thank the speakers in advance for their time today and sharing their work in this remit. So over to you, Greg.
Hello, everyone, and welcome to this seminar on how we've developed the Health Index for England and how my colleagues in Northumbria Healthcare NHS Trust have taken that idea and run with it to produce something that's much more exciting, in my opinion. But it is all exciting, so I hope you enjoy today. I'm Greg Seeley. I head up the Health Index and Projections team in the Health Analysis and Pandemic Insight Directorate, or HAPI Directorate, in ONS. And as you can see on this slide, it was initially planned that we would be presenting this work in the RSS International Conference last year. Unfortunately, due to the Queen's death and the resulting mourning period, ONS staff were not able to attend and present at conferences during that time. So I'm very pleased that we are now able to present this work to you. As I said, it's very exciting stuff. It's also moved on a reasonable amount since the presentation we would have been able to give back in September. So in some ways, it's a blessing in disguise that we're giving this presentation now rather than a few months ago. But anyway, let's jump into the presentation itself. So what we'll cover is why build a health index at all, and why should ONS be the ones to do it, how we've built it, what we've put out into public space, and how you can use that, and then what we will develop next and what's in the pipeline. After that, I will pass to Cara and Chris, who will talk us through the exciting work they've done on the local health index. But to begin, why should we have a health index at all, and why should it be ONS who produce it? The health index came from the Chief Medical Officer's 2018 annual report, which said that there was a need to be able to track health for the longer term and to measure health in its broadest sense, including health outcomes, risk factors, and the determinants of health. Sadly for Dame Sally, she was CMO just before Chris Whitty took over and the pandemic made CMO a household name and title. But she was the originator of this idea that we should track health in a similar way to how we track other forms of national progress. So we have GDP and the price indices as a way of tracking the nation's financial progress over time, but we don't have an equivalent for health. And it would be useful to be able to understand our progress in improving our health and maintaining our health over time when we're thinking about the state of the nation as a whole. And why ONS? Overall, ONS delivers data and insight for the public good. That's our official role. You will have seen, hopefully, during the pandemic that we have put out a metric ton of statistics on the coronavirus pandemic and its impacts on mortality, how those differ by ethnicity, occupation, everything like that. And before that, of course, ONS has produced statistics on all sorts of life events. We have baby names as one of our most viewed stats. We collect information on births and death registrations and publish those, as well as wider societal factors, which makes us perfect for capturing the type of information which Dame Sally suggested should be in the index, these wider determinants, not just health in its simplest sense. ONS has a 5-year strategy for health stats, which is outlined on this slide here. And a lot of this, again, aligns with the aims of the health index of looking at health in a broad sense. We want to produce stats to help answer questions about broader population health challenges and stay prepared to respond quickly to future health challenges. And if we can track health over time and begin to see signs of decline sooner than we may have spotted them otherwise without a time series measure, then the health index fits the bill of what ONS is aiming to achieve in helping the public in that sense. And again, we're looking to lead and shape the UK statistical system's role in health and social care. And this means ONS takes more of a role in health. Yes, there are departments that focus on health directly, such as the Department of Health and Social Care. And when the health index was initially proposed, a governance group featuring the ONS, DHSC, and the Cabinet Office was put together to determine how the health index should be taken forward. And that group agreed that ONS was the best candidate for producing the health index, as our status as being a non-ministerially led government body meant that we could ensure the health index remained independent of policy pressures in measuring health over time. So, how have we actually constructed a health index? I've spoken a bit about the need for a broad definition of health already and capturing these wider determinants. And of course, health is such a nebulous concept. It means an awful lot of different things to different people. And so in order to achieve support from the public and experts alike on something called simply the health index, we needed to make sure we were aligning with an established and accepted definition of health. And the World Health Organization, or WHO's definition, met our needs. They embody this idea that health is more than simply the absence of ill health, but it's a state of complete physical, mental, and social well-being. And that's something that can only be achieved by thinking about health in this broad sense. Using both this WHO definition and Dame Sally's initial vision, we aimed to produce a health index which describes health in its broadest sense and asks, are people in this area healthy? Do they lead healthy lives? And do they live in healthy places? It needed to provide an independent view of health in your area, again achieved by ONS being the ones to take it forward, and compare health over time across geographies and across different dimensions of health. We've developed this health index with all of these points in mind, fleshing them out with our own research, consultation with an expert group and the public, and have used best practice in index development techniques. And I will explain more on each of those points momentarily, including some of them right now. I just mentioned an expert advisory group. From the initial conception of the index through to publishing our first proof of concept version at the end of 2020, we worked with a group of 30 organisations featuring central government departments, including DHSC and HM Treasury, arm's length bodies such as NHS England and NHS Digital, academics and think tank organisations, and representatives from the voluntary and charitable sector as well. The statistical methodology for the index follows an established approach to building composite indicators. So the Competence Centre on Composite Indicators and Scoreboards, or thankfully simply COIN for short, is part of OECD, and they have a 10-step guide for building indices which we followed, adapting where necessary to our needs. We can summarise these 10 steps shown on this slide into 4 stages of development for us, also shown on this slide, which I'm going to describe briefly in turn. I've just spotted a question in the chat, but I will come to questions at the end if that's okay. But there is much more detail on this full process in our public methodology article as well, if there's anything that I miss. So we began this whole process by conducting a comprehensive review of the existing data landscape for health. This included frameworks such as NHS's Quality and Outcomes Framework and existing indices such as the English Indices of Multiple Deprivation to confirm which sources are those other frameworks deemed suitable for measuring health. We also comprehensively reviewed available health data in general, as we expected there may be emerging sources which had not yet had opportunity to be used in these frameworks. And again, ONS was well placed to be conducting this data review, as we have tools both existing and in development, such as the Health and Care Data Landscape tool, to understand exactly which data, official and otherwise, are available for many of the concepts of health we were considering. The result of that review was a conceptual structure of how existing data could inform health on our three domains I presented earlier: the healthy people, healthy lives, healthy places. And our ideas of the themes or categories we thought would be meaningful groupings for these different topics to inform the health index. We worked with our expert advisors to get their input on what they felt should be in scope but wasn't present, and of course anything which they felt we had included as in scope but shouldn't be. Overall, we want from the health index a value for health which is an aggregate of existing information and is trackable over time with a clear direction of change. So not all the data used by these other frameworks was suitable for our purposes, and some of our data inclusion principles are outlined on the slide. A couple of particularly important ones I want to highlight are the need for us to measure health rather than health services. By this I mean, if an existing metric is too tied to health service activity, it might measure changes in service rather than a change in population health, which was not suitable for our needs. For example, if we were to think about a measure of the need for social care, the health index could include the number of people eligible for local authority funded social care, as is measured by LAs at present. But if the thresholds for eligibility changed, but the health of the public did not, the number of people eligible would change, even though, and therefore our index would change if we included that, but health of the population wouldn't be changing. So this is something we were keen to avoid. Similarly, I've mentioned here clear direction of health improvement. We had many a philosophical discussion on our different potential indicators, especially on health conditions, of whether prevalence or incidence was more important to measure as a sign of population health. There are complex questions such as, if we think about a measure like dementia, as health services and health care improves, we can see people living longer with dementia and it affecting them less, but then still having it if we haven't been able to cure it. So if we see the number of people in the population with dementia increase, that's not necessarily a sign that their health is getting worse. They may be able to manage it for longer thanks to health changes. So we had to be very careful about what we felt was a meaningful measure to be able to say an increase or decrease in this meant that health was improving or declining. And it's only in being strict like this that we're able to produce something where we are able to say health is improving over time or declining over time once aggregated between our many, many indicators. So now we had our indicators, our different data which met our definition of health and fit the bill in terms of our inclusion principles. We combined these using statistical factor analysis. What factor analysis does is look at the relationships between all of our variables we can observe and aims to reduce the number of elements we're measuring based on the relationships they have in common. This means that if we have multiple indicators measuring mortality in some way or another, we would expect those to group together into a factor or subdomain, as we refer to them in the index. We need the index to be accessible to users, so we were not fully beholden to the first factor solution as suggested. If factor analysis provides you an output, it looks at the common variance which your input data explain and tells you that this is factor one, but unsurprisingly, factor analysis will not tell you what factor one actually means, but we would then interpret the factor analysis results to tell you that if, for example, life expectancy and avoidable mortality were to group together, a potentially meaningful name for that factor, or for us as subdomain, is mortality. But it could be that two indicators that don't have an obvious combined meaning would group together in the statistical solution that we don't feel would be very meaningful to users. In those cases, we explored statistically acceptable alternatives which better fit the conceptual structure we identified at the start of our development when first reviewing the health and care landscape. This could be moving an indicator from one domain to another. For example, our healthy people domain is effectively health outcomes, and healthy lives domain is effectively individual risk factors. And there are some conditions such as diabetes and high blood pressure, which could be a risk factor and are a risk factor for other things, but are also outcomes in themselves. And so if they didn't fit in a clear place in the health index, we would test them in those different domains to see where they best fit statistically. Ultimately, even though we were aiming to make our groupings meaningful to the public, we rejected any factor solution which didn't group indicators together. So, for example, if we felt indicators A, B, and C must go into a group together because we thought that this was most meaningful, and yet even if you tried to force a single factor solution for just those three indicators, they wouldn't fit together, then they wouldn't be included in the index. Every subdomain based on these factors is the result of a combination which would happily fit together into a single factor when we're explaining the existing variance. I mentioned that one of the features of factor analysis is to use it as a reductive tool, so to reduce the number of elements which need to be measured. In the same vein as how we were balancing user needs and statistical evidence for determining the groupings a moment ago, we used the same principle when removing potential elements. An example of this is we want to have a comprehensive enough collection of indicators that users can find a suitable proxy for whatever it is they want to measure. And so actually reducing to the fewest number of indicators possible isn't in our best interests for making something meaningful to analysts and the public alike. But there are places where two indicators explain such similar variance in the overall data that including both doesn't add much power. And one particular example of this is educational attainment. Our initial version of the index back in 2020 was looking at including attainment at different key stages as different indicators, but we found they explained such similar variance in the overall model, this latent factor of health, that it wasn't sensible to include multiple when they were measuring such similar things. So we still include a measure of attainment. We've got attainment at GCSE level, but we haven't included these other levels to avoid redundancy in our indicators. Finally, on this factor analysis section, I've explained that each indicator explains a certain amount of variance in a latent factor or subdomain for us. And these did not just determine which indicators sat within each subdomain, but also determined their weightings within each subdomain. Not everything in the health index is weighted equally. So if an indicator explains more of the variance within a factor than its colleagues in that subdomain, then that indicator would have a greater weight, and their weights are directly proportional to the total of the overall variance explained. Each indicator can only fit in one subdomain in our solution, whereas in factor analysis, it could be that something loads onto multiple factors. But we felt, again, this was simplest for user interpretation of what our index is doing. And that's a key principle throughout all of this. If I haven't made that clear already, that this is a new concept and health is something which people expect to understand better than a financial measure such as GDP or the retail prices index. And so we wanted to ensure how the health index has been constructed is as transparent to people as possible, whether or not they fully understand factor analysis. They can understand the steps we have taken. So a lot of what we've aimed to do in the construction of the health index, including having results available at every level of the health index, is about making it clear to people how our overall figure is created from the source data. So let's talk about creating that overall figure. Our final step, now we had a full set of indicators organized into subdomain topics and domains, and then into a top level index value, was how we actually calculated that top level index value. We've used time indexed standardization with a base year of 2015, which was most appropriate for our data availability when first setting up the index. With this calculation, every level of the index has a score of 100 for England in 2015. And any score higher than that means that your health is better than England. Any score worse means that your health is worse than England in that year. So your 2018 score could be 105, and that means that your health is better than England in 2015. And it's only through having this sort of time indexed base year that we are able to have a meaningful figure that you can track over time. After this, we aggregated to different geographical levels by using population weights. So if two local authorities are in the same region and one has twice the population, then it will have twice the weight in creating that region's health index scores. And again, we aggregated from there to England overall. This means, and that aggregation is a simple weighted arithmetic mean. We've then done further standardization in this form shown here of 10 points higher or lower on the index represents one standard deviation better/worse health at each aggregation stage, because otherwise with a simple arithmetic mean, we would just get results coming closer and closer to 100 and we wouldn't maintain that scale. The result of this is that every component of the index at any topic or geographical level is presented with the same scale over time, with 100 as its base result, higher or lower score than 100, meaning higher or lower, or sorry, better or worse health than England in 2015, respectively. And every year on year, a higher score than the previous year for that same area, or the same year for a different geography means that your health is better than that area or time you're comparing to. Following all of these data and stats jiggery-pokery, we're left with a health index which covers the key areas of health, hopefully. It combines data from over 50 data sources to produce a single independent measure of health. And the hierarchy of the index is presented on this slide, with the health index along the top, our three domains of people, lives, and places, each being a column, and all of the subdomains within each of those domains is presented underneath its respective domain. So healthy people has 5 subdomains, healthy lives has 4, and healthy places has 5. Within each of these subdomains, there are typically multiple indicators. In a few cases, there is just the one. And the example shown here is that in protective measures in healthy lives, so your individual circumstances which affect your health, we have people's attendance of cancer screenings and the coverage of child vaccination in that area, not including COVID vaccination. So every domain is underpinned by these subdomains. Each of those is underpinned by indicators. And again, the aim with this structure is to make it clear to people what the building blocks of health are in our overall measure. And geographically, these results are available at England level, regions of England, local authority, both upper tier and lower tier, and integrated care system level as of our previous release. We match our data inputs as far as possible to the year they relate to, and we produce this comparable back series to 2015, so we can track how health changes over time. We knew that, again, in getting people to accept a measure such as the health index, if we presented the health index as it's first released by saying health is, ta-da, 8, that's not very helpful to people and not meaningful at all. But if we're able to show upon even that first release what some time series looks like and the trajectory of health, then that really helps with engagement, we feel. And then, of course, makes it even more complex when a pandemic appears moments after you started building this sort of thing and creates one of the greatest shocks to health that anyone has ever seen. So We have published the Health Index following this structure, and I want to show you what we have done and what you can do with it. One way that you can explore the Health Index scores across England is to use this tool on our website. This is an interactive map which appears as the last figure in our National Insights Bulletin. What we've looked at there was just Health Index scores at national level, or looking nationally at local trends. But there are more tools we have for understanding Health Index at local level. This slide, and we'll share all slides afterwards, has links to our latest outputs on the Health Index, both our National Insights Bulletin, which features that map, and tools such as our Local Insights robo-journalism piece. This is a particularly exciting one that we're very proud of. It uses semi-automated journalism to identify the key features of the Health Index's results for your local area. As you've seen from both of these charts, or both of these outputs, these are showing data up to 2020, and I will say in a moment a bit more about our plans for 2021 data and beyond. I've also seen a couple of things in the comments which we'll be able to talk about a bit later on, questions about UK level index, for example. But before I go on, I do want to praise my colleagues for this specific robo-journalism piece. This is actually not produced quite so much by my own Health Index and Projections team, but the design of it was led by ONS's digital journalism team. And it is now, this specific webpage is now award-winning. It has the Campion Award for Excellence in statistical presentation. So we are very pleased with this and would recommend you give it a look. So what do people actually think of the index? Some good things. It is simple in showing you a top level measure of health, and can give you a good overview of what health is like in an area. It reinforces their existing knowledge, which is fair enough, given that it's composed of existing data sources that are publicly available for the most part. And its independence has been praised, the idea that it is separate from policy priorities, but still able to show some of the impacts of policy interventions. And there is a lot of support for wider determinants of health being recognised within the index. Finally, just as one deeper dive into these sorts of comments, we had a glowing comment from Jim McManus, who is president of the Association of Directors of Public Health, for our release of 2020 data in November. Jim talks about the Health Index providing a unique overview, that it can help to compare and track the impact of policies and programs and support decisions in relation to health initiatives, with that ultimate aim that we all have of allowing people to live longer and healthier lives. While throughout a lot of this, I've been talking about Health for England and variation across England, we could similarly have been talking about a region, an ICS, a combined authority or local authority, because of the Health Index's flexibility to look at health at all of these different levels. And this slide is less for presentation here, but more for people's reference. Integrated care systems are quite a new addition to health geographies. They've only been set up in recent years, and it's one of the geographies that the Health Index presents. And I believe that the Health Index is one of ONS's first outputs, which presents results at integrated care system level. ICSs are organisation partnerships that come together in the ways that are described on the slide, and there are 42 total in England. There are plans underway in the same way that ICSs are being set up to have equivalent systems set up across the UK. So for the different devolved administrations, they're in different stages of setting up similar. Scotland brought health and social care together in 2016 with 31 integration authorities, and Northern Ireland is developing its own similar integrated care system, and Wales is planning integrated groups, approximately 7 across the nation. So what we're presenting for integrated care systems could be presented at a similar level for those devolved nations in the future. So what is next for the Health Index? I've already teased that a bit by saying a bit about the UK information. But the first thing is Health Index 2021 is going to be published tomorrow. I wish it could have been published today, both because it would make today a bit less busy for me. But it means that there will be more results than you have seen here tomorrow. That is still not very timely, we appreciate. The Health Index does, of course, become limited by the fact that we have over 50 source indicators. So realistically, we cannot publish that quickly without either omitting some of our indicators, which are published more slowly, or waiting for everything to be available and then working from there. It doesn't help that many health data sources have been impacted by the pandemic, both in the results they show and the interpretation those need by their producers could limit how quickly things are published. But similarly, many sources just weren't collected for 2020 and 2021, if not longer, because of limitations in running surveys, for example. But we are very pleased that Health Index 2021 is published tomorrow, and it represents a continuous improvement on timeliness since our first full release. So we released Health Index 2018 back in December 2020, and then ran a public consultation for 3 months to collect people's views on the value of the Health Index and how they would want it to change. Following that, we produced Health Index 2019, published in March last year. 7 months later, Health Index 2020 in November, and now 7 months later, Health Index 2021. So recently, for every 7 months that pass, we cover an extra year of data, which is quite good for timeliness in general until you think about how big a lag that is. And we are exploring options for how we can present something that is more timely. Overall, there are 3 key themes which our user feedback keeps highlighting as areas for us to improve. And these are not mutually exclusive. They're shown on this triangle here, but they do all require resource to explore what's possible and not. So it is likely they will not all progress uniformly. However, our overall goal is to have a more timely UK level health index that's available to greater geographical granularity than present. Importantly, from our perspective, we'd like to continue a partnership approach where we actively hear what is most useful to users in terms of data and insights that we can provide with the Health Index and wider ONS data, and also what support is needed from us to make best use of these data and insights for you. It would be great to hear if you agree with our development priorities and or whether you think there are other areas that we need to focus on. The UK level index, for example, is particularly prominent at the moment. There is a great push within ONS and more widely for greater coherence between data for the 4 nations. We are very keen that while using Welsh data means it's possible to produce a health index for Wales, and similarly, colleagues in the Red Cross have actually produced an example of what a health index for Scotland could look like. These are useful tools, but only in themselves for understanding similarities and differences within those areas. We know it's just as important for the Cardiff Council to understand how they compare with Swansea as how they compare with Bristol. So the challenge to a UK level index is how we harmonise the similar but different data which these different nations hold in order to make something which is truly comparable between them and can be summarised into a UK level health index. Effectively, a scenario we're keen to avoid is, while we have a great amount of respect and make great use of the indices of multiple deprivation, the fact that the Welsh IMD and the English IMD are not directly comparable is the type of situation we want to avoid with the health index. A couple of other areas that we are progressing at the moment with some quite high profile colleagues. Our friends in the Alan Turing Institute have recently completed a comprehensive review of our methodologies and made some suggestions of alternatives we could explore in places. This is available in pre-publication with the link there that you'll have in the slides later on, but will be published in one of the RSS journals. And similarly, Professor Sir Michael Marmot, I always lose track of which way around those titles go, but either way, a very esteemed colleague has expressed support for and interest in the Health Index. So we're working with him and his collaborator, Peter Goldblatt, to report on the comparisons and contrasts between the Health Index and the Marmot Beacon indicators. So the Marmot Beacon indicators have a slightly different aim. They're aiming to measure inequality within an area rather than looking at the differences between areas. But we think there is great value in seeing where the Health Index differs from Marmot's indicators, and where those differences are arbitrary versus where they are meaningful to the different things we are measuring, and then understanding what is the impact of us doing things differently and how can we make our measures of health more consistent and ultimately improve both. I'm conscious of time, so I will not say too much more before passing over to my Northumbria colleagues, but we know that when it comes to anything to do with public health and health in general, as I've said, it's a very broad topic. And so to explore an issue, you'll want to consider a wide set of evidence. The Health Index aims to be one tool in a toolbox rather than everything to everyone. And of course, the greatest impact that comes from analysis will be when analysis uses a combination of tools or resources. We've heard from our stakeholders that ONS can add value by connecting the Health Index to related national insights, relevant associated data, and neighbourhood information. This has led to the idea that we could bookend the Health Index, adding value at one end by signposting national insights, particularly those from ONS data, and at the other end by considering more granular data, such as the census, the IMD, and local data, which you'll hear more about very, very soon. We recognise the value of exploring the Health Index alongside these wider and more granular data. So we plan to make the Health Index available through other dashboards, such as OHID's Fingertips tool or NHS's Model Health System. We also plan to improve the search terms for healthcare statistics, which is a tool that signposts to statistical publications, irrespective of which government department produced them. And this will make it easier to connect from a Health Index topic to the other relevant stats. And finally, on this, we're exploring causal inference with the Alan Turing Institute, looking at how existing evidence and research can improve our understanding of causal relationships within health. Our current plan is to review causal information on a topic-by-topic basis to understand what evidence already exists, the value of that work and its feasibility, for then expanding to a greater way of presenting causal impacts in the Health Index structure. And one very last bit from me, alongside the development of the Health Index, in getting data together from so many sources and formatting them consistently, we have already overcome one of the greatest boundaries to any sort of health modelling using data. So alongside the index, we've built a simple and flexible health projections tool. And what this looks like right now is shown on your screen. This aims to show the trajectory an aspect of health might have into the future, both in the absence of intervention and if there were a simple intervention as determined by the user. Similar to the Health Index itself, we've developed this tool with an expert advisory group, including epidemiology modelers at Newcastle University, OHID's modelling team, ONS's population projections team, and data ethics experts. Our aim is for this model to show how changing one aspect of health will impact others, how that would have different impacts on different parts of the nation, and how changes could affect health overall. And of course, this is very closely linked to the causal inference work I just described. So the image on this slide is a screenshot of the model in its current form, and the model is currently hosted online in a private beta, where anyone who is interested can access it for user testing if they provide us with their Gmail account. So if this is something you would like to support, please provide me with your email address and we can get you set up and exploring what this tool can do. And I said finally for me, there's one tiny other thing. We know that our data visualization as presented on the ONS website, has a few limitations. The ONS website has many strengths. Flexibility of its data viz is not really one of them. So similar to our private hosting of the health projections tool, we're looking to host a Health Index Explorer platform and collect user feedback on what types of outputs they find most useful. This top left chart allows you to plot any two aspects of the index of interest and weight your data points based on information such as deprivation score from IMD, population size of the local authority, average age in the local authority, or another demographic measure. And you'll be very pleased to hear that is it from me. I will stop talking and will hand over to Chris and Cara. Chris and Cara, I'm very happy to either allow you to do your best Chris Whitty and I can click the next slides for you, or for you to take control, whichever you prefer.
I think we'll stick with you, Greg. Is that all right? Super. Okay, yeah, so thank you very much for the introduction, Greg. I don't know how you keep saying we're the most impressive bit, and we're definitely not that. Those stats are massive. So I think it's prudent if we just start with explaining what Northumbria is. So if we go to the next slide, please. So if you don't know, Northumbria NHS Trust is one of the largest trusts in England by size. And you can see from the map here that we span from just above Newcastle there up to the Scottish border and then right across to the left to Cumbria. We have about 500,000 people in our sort of catchment, and we are split across two local authorities. So if we think back to the ONS Health Index for England, we have two scores from the Health Index that ONS has published, one for Northumberland and one for North Tyneside. So I think it's probably best now that I explain what a lower super output area is. It's a bit of a mouthful. It's LSOA. So within our two local authorities here, we have 328 lower super output areas. So each one contains about 1,500 people, which makes our total population of 500,000 people. Okay, next slide, please.
So as we've seen, the Health Index for England provides that holistic measure of health for each local authority. It takes that wide variety of health metrics at local authority and gives that, let's say, a holistic picture of health. And as we've seen, so that feedback there that Greg presented from Jim McManus, for example, directors of public health, love the Health Index for England. It's a really, really good tool, and the ONS, the consultation of the ONS ran. That was definitely the feedback they got. We really love the Health Index, but what there was appetite for was for the exact same methodology to be applied, but at those smaller geographies. So taking an example again of a director of public health, it's great being able to see how well Northumberland compares to North Tyneside, but there's obviously a lot of appetite from local health officials to be able to understand variation within their local authority area, as well as between local authority areas. So in collaboration with the ONS, we've piloted an experimental local health index for our Northumbria population, which we're hoping could become one of the most granular small area health tools available, leveraging that kind of that methodology that the ONS have already taken for the National Health Index, and then pushing that down onto those 328 low super output areas in our catchment area. Next slide, please, Greg. And you'll have to press 3 times for this one. I left some animations on, sorry. So the reason we're showing you this slide here is we want to really just expand on the value of taking a place-based approach to health and showing you really that on a sub-local authority footprint, what the variation in health outcomes can look like. So this is actually a map of deprivation produced by one of Greg's colleagues, Rob Fry, head of visualization at the ONS. And what you're looking at there is a map of a former mining town in Northumberland called Ashington. And obviously those red areas are the more deprived ones, those green areas are the less deprived areas. And it's really just to show you what kind of variation in outcomes you can expect at low super output area level. So you've got some very, very deprived areas almost existing, as Michael Marmon would say, cheek by jowl with those very, very affluent areas right next to them. So that's the reason why we're taking this approach in such a small, granular geographical area. Next, please. And so expanding a little bit on that around the value of the local health index. So it really is a novel approach to measuring health as an asset, not just as a deficit model. So a lot of ways of understanding health is the prevalence of something or the incidence of something or mortality rate or hospital admissions. But health is much more than that, and so I say having those 56 indicators, it can become significantly more granular as well by taking the geographical approach that we've taken. And we're hoping that the outcome from this can be new ways of understanding inequalities in health, new ways of visualising how health is geographically patterned. And we've mentioned there on about a population health laboratory approach, and what we mean by that is being able to identify what we probably call unexpected or unexplained variation in health by using the local health index. And then because of the way the health index methodology works over time, if we identify there's an issue and then we pilot some kind of intervention for that issue, we can then use updates to what would be the local health index year on year to be able to see if those interventions have had an impact holistically on health as a whole. Next, please, Greg.
So we definitely believe that there is huge value in this local health index approach. However, building the local health index as it is today has not been without its challenges. And I think it'd be silly of us to sort of produce and present to you today to say this is a final version. It's definitely not. It is a pilot. We do have some sort of I'd say serious, but they're not. They are significant assumptions that we have had to take due to some constraints that we faced. So if we just outline those constraints and challenges now, most of them did arise due to the small geographies we're talking about. So the first one here is about getting the right data. So sometimes the LSOA level data just wasn't available, or us as a trust weren't able to access it. So we did have to work very closely with our local authority counterparts and also make substitutions where needed to get the data and the 56 indicators that we wanted. The next challenge on here is about small area statistics. So when you dig so deep into that map, you do get areas that are so small that the values of some indicators would be too small to share based on sharing agreements and privacy and ethical reasons. So for some cases, we just had to assume that the indicator value was 0 in some LSOA sort of granularities because there wasn't a way for us to get that data. And the third challenge on here is about, again, it's due to the digging deep in the granularity. So LSOAs, sometimes there wasn't a suitable substitute. So we had to come up a granularity from LSOA maybe to MSOA, which is a middle super output area, or maybe to ward as well. So we've just had to make some assumptions and really run with the data as we had it. And in order to do that, we've demonstrated the art of the possible for this. Go next slide, please, Greg. Thank you.
Thank you. So the data is being drawn from a wide range of sources and in collaboration with our local partners. So we've drawn publicly available data for almost every indicator that we've built into our local health index. And most of that has come from public sector sources. So we've drawn a lot from OHID's data, we've drawn a lot from the ONS, and we've drawn a lot from our local authority partners as well. But we did encounter some issues with that, and part of that is around access to data sets such as the primary care mortality database and hospital episode statistics. So those are data sets that are not open to any analyst to access, and in some cases there's actually no legal basis to access those data sets if you are not working directly for a local authority. So we're really grateful to our local authority partners in Northumberland and North Tyneside councils respectively, because we wouldn't be able to have got data on, say, neonatal mortality, suicide, and a few other very sensitive topics without their help and guidance. Next slide, please, Greg.
So this next couple of slides are about our methodologies, and it really is hats off to ONS and Greg's team here. I've worked with a lot of Python scripts. I used to be in a consultancy firm, so I've seen a lot of second-hand Python, and the ONS has got to be the best that I've seen in a long time. So it was well commented and easy to pick up and adapt. So that being said, we picked up the Python scripts that they'd written, and we've adapted those and their health index for England methodologies to basically produce the health index values, the scores at this LSOA level for 2019, so one year rather than time series for our Northumbria. So our England basically is Northumbria. So we followed much the same logic as the ONS did. You heard the extensive efforts and methodologies that went into to find the data framework, the landscape of data, as well as that factor analysis. So we did lift and shift quite a lot of the work that ONS had done. So we've tried to marry our indicators as much as possible to the ONS indicators. We have used the same factor analysis and the weightings from them, and we've used the same methodology to centre the indicators at 100 as well. The last step on this slide is the benchmarking. So this is something that the ONS don't have to do because they've only got their health index for England. So we wanted our results to be comparable to the publication from the ONS. So in order to do that, because by design, we each respectively centred our indicators at 100, 100 had a different meaning in both publications. So we have shifted by using a percentage difference. So for example, if the ONS published that their 2019 Northumbria average was 126 and ours was 100 by design, we would shift by 1.26 across all the indicator, subdomain, and then the overall scores as well. We benchmarked every point that we could. So next slide, please. I'm mindful that Greg did quite a lot of the methodology talk, so I tried to pick up a piece that he'd not talked about, which was more on how we homogenise the data. So when we think about that statistical transformation, if you're mathematicians, you may know that, well, from my experience, definitely, we love the normal distribution, that bell-shaped curve, but unfortunately, data is rarely like that. So on the left-hand side here, we have the raw indicator, and you can see there it's got a right-hand side peak where the skew is and a left tail. So you can see in the sort of table underneath that the original skew and kurtosis values were minus 0.7 and minus 1.7. And you can see that if you applied the log transformation and took the same values, calculated the skew and kurtosis again, you had a total. So if you added the sum and kurtosis together, you had a lower value of sort of the skew and the tailedness when you applied the log transformation. So you can see that effect when you shift the data and transform the data in that way on the right-hand side. The skew has remained, in fact, increased if you look at the skew calculations, but that tailedness has decreased, which is what we want to do with the transformation. You can also see there that the scales has been affected by the log transformation, so it's much narrower at 4s rather than 85s, and then you would normalise that on the 100 using that time index normalisation that Greg talked about. Next slide, please.
So what we're looking at here is just a very simple scatter plot. So we've got the LSOA level IMD score, the index of multiple deprivation score there on the horizontal axis, and then on the vertical axis we've got our local health index score for each. There's the overall local health index score for each one of those LSOAs. And really the point of showing this is really to show the value of the local health index as opposed to other indices such as the index of multiple deprivation. So you can see there that broadly speaking, there is quite a clear correlation between the two there. Generally, where we'll find a high level of deprivation, we'll find a low health index score. But there are quite a few there where they don't look like very deprived areas, but their health outcomes, at least going through the local health index, are not great. And from a very local kind of commissioner perspective, those areas that are not very deprived when thinking about local services and where our resources are going would be areas that if you were just using the IMD alone, you might not prioritise. But what the value of the local health index is by taking a very, very granular approach to those health indicators at that very small level, you can find some that are not deprived at all, but where the health outcomes are not good. And we talk about a lot of hidden need in deprived areas, but theoretically speaking, this could be picking up on some hidden need in our lesser deprived areas as well, or less deprived areas where there might still be some significant pockets of poor health that would not ordinarily be seen. Next slide, please, Greg. Now, this is where we were hoping to do our live demo. Would I be able to share my screen very quickly and show you how all of these charts and graphs look in an interactive way rather than in PowerPoint? I'll try and do that now if I can. And then I'll pass back over to you, Greg, as soon as I've done this.
Cool. I was just going to say I had taken control in the first place from someone else, I think Hera, so it might be Hera that'll need to restart the slides after this. but otherwise we can see your screen now.
Fantastic, thanks, Greg. So this is the interactive visualization that's being produced for the local health index. So this is being produced by a private consultancy company called Lane, Clark and Peacock, who have done the visualization for the National Health Index in the past as well. So you can see here, we've got our map of Northumberland and North Tyneside here. And we can either enter a postcode or we can navigate straight to an area. So if we wanted to navigate to one area, for example, so let's take a look at this area of Blythe once we've put in part of the postcode. So you can see there, you've got the map, it isolates that LSOA there. And what we've got on the right-hand side here of your screen is what we're calling the donut chart. So on the very outer ring of this, you can see a kind of a colour representing either a high or a low score. So the lighter the shade, the better the score. All the way around the outside there. So that's where those 56 indicators are. And then moving into that middle ring there, you've got those subdomains. And then in that inner ring there, you've got those full domains. So what you can do is you can very clearly see that there are some ones sticking out there. So for example, this is based on diabetes prevalence from GP data. So, and that model estimates from GP data, I should say. You see that's sticking out as quite a low score as well. Alcohol misuse is sticking out as quite a low score as well. So you can select any one of these indicators and visualize it on the map. So let's just take that diabetes one, for example, and then view Northumbria for that. So here we're looking at where theoretically we're estimating, based on local health index, high prevalence of diabetes. So, and from us, from a local perspective, seeing that kind of pattern on that map is not unexpected. That is what we would expect based on what we know locally about the area. And also what you can do is you can, and then you can click on any one area and then see how that compares to the others as well. So this is really, really valuable for us to have. Especially being able to break it down, so you can visualize a domain, for example, you can visualize a subdomain, and not everything has worked perfectly when we've been visualizing this. So for example, if we look at our healthy places domain, we'll see quite a few dark areas, so representing a poor score in our rural areas of Northumberland. Some of that has been driven by the methodology behind the health index. So, for example, access to green space. Some of those areas are the greenest and most spacious areas you'll ever go to in your life, but they have a low score for access to green space because access to green space is worked out by actual statutory marked out areas of green space. So there's a few things like that maybe don't necessarily apply at LSOA level. But overall, this is a fantastic tool that LCP have built for us, a really great way of visualising the local health index. And if I can pass back over to you, please, Greg.
Thank you. As I said, I think I'll need Hira to put the slides back up, if that's okay.
Know what the next slide is, so shall I start?
Yeah, you make a start while I navigate to it.
So it's all about the case studies and how we're using that local health index. So my favourite case study today is actually like a false positive finding. So there was a local GP who noticed that their local health index displayed dementia rates as relatively positive in rural Northumberland, whereas we know from our demographics we do have an ageing population out in rural Northumberland. So we worked with a few different stakeholders to see what we thought might be driving that data insight, and the hypothesis is that not that the diagnosis rate and the dementia prevalence is lower in reality in rural Northumberland, but actually it might be attributed to limited services and then a potential inequality in our healthcare delivery out towards Cumbria. So in order to test that, we've set up a small task group who's going to go out and dig deep basically into the challenges that the healthcare providers are facing and devising any potential solutions for that. And internally, we're also looking deeper into the data. So there's something called a 4-ACT test, which is a test of cognitive ability. So we've got that data internally as the trust. So we're going to look for demographic patterns within that data. So hopefully that demonstrates the value of where the local health index tool is being used, and through engaging the right people, the right stakeholders, we have hopefully identified an opportunity to improve the dementia identification within our delivery of service as a trust. Next slide, please. Thank you.
So this will be our last slide. So really, we hope we've demonstrated the art of the possible for the health index methodology and what it can do at a local area. So we are hoping to continue working on this. We're hoping to take it forward and do some more work with it. So the Trust and the ONS, we're working together to produce a business case to launch the local health index and try and put some resource behind it. And in the meantime, we're going to keep working with it. We're going to keep using it to identify where we can see variation in health. And then trying to use our contacts in the trust and in our partner local authorities who are 100% on board with this to try and identify those inequalities and then, and then try and do something about them. And we're really excited about it. And just a big thank you to Greg for facilitating this.
Thank you so much, everyone. That was absolutely amazing. It's so great to see all this work that you've done, and really appreciate the time you've taken to join us today and just update us on all things health index. So there were some questions in the chat. They were, I think, more aligned with when you were doing your presentation, but obviously if there's bits that, you know, both yourselves, Cara and Chris, if you want to kind of like mention anything, more than happy for you to. So I think one of the first questions, Ben, for you, for Greg, were from someone called Ben. He was out of curiosity. Did you have any input from the social care sector?
Not directly, sadly. So we've been working with think tanks such as Health Foundation and King's Fund, who do a lot of work on adult social care policy analysis and effectively lobbying government to finally produce the social care white paper that's been promised for many, many years. So we have that perspective of expertise in social care. Unfortunately, actually getting social care sector to feed into the overall health index was more challenging because partly, I mean, as I alluded to earlier, but didn't say the exact timings, much of the health index's development began in very late 2019 and continued into 2020. And this meant that a very obvious public health pressure appeared in mid-2020 and limited how many people we could work with. So we aimed to bring in more organizations to help with the expertise that our expert advisory group was providing, but we weren't able to put in more, especially in the care sector, given the pressures it then faced at the start of the COVID pandemic. So hopefully my answers to other questions are a bit more satisfactory than that one. Sorry, that couldn't be better news, but it is an area that we are very keen to improve our data on in future versions of the health index. I have a history of working in DHSC on social care analysis, and it does feel like it's a big gap that we've got many named conditions and quite a limited indicator of frailty within the health index, but not much that really identifies care need. And I feel like that's one of my personal priority areas for us to improve upon.
That was great. I'm sure that, Ben has said that you've answered his question very clearly, so that's great. So the other question was from Brian, who mentioned, are the variables proportions or counts? Brian, are you happy to probably?
It's a mix.
Okay.
Sorry, Hira, you can go ahead first.
Oh, no, I was going to say if Brian wanted to kind of let us know was it? I think it was like the beginning of the first few slides, but I did feel like it was a mix. You could kind of change between them.
Yes, so the vast majority are proportions of some form or another. There is nowhere where we are limited to raw counts. We always standardize our data so they are meaningful comparisons between areas. So, for example, we capture rough sleeping, which I forget their current acronym. Is it DLUC, DLUHC, the Department for Levelling Up Housing and Communities, that used to be MHCLG and before that DCLG. They produce rough sleeping statistics based on a single night of the year in late October, I believe. They do a count across the whole of the nation of the number of rough sleepers. And in the places where we've used that data, we have then adjusted that to rough sleepers per 100,000 population in a local authority to ensure that when we're looking at these sorts of figures, we produce something that's more comparable between local authorities of different sizes. So majority are proportions or effectively become proportions through that sort of standardizing, even where they weren't in the first place.
Okay, thanks. That's great.
Thank you so much. We have another question from Nicola Shelton, who asks, how will you address changes in geographical boundaries over time?
This is a really interesting one because I think it has quite different answers for the health index in its current form and the type of work that Cara and Chris have been doing. For us right now, it's very manual. So between our first version of the index in 2018 and this 2021 release coming out tomorrow, there have been various changes in geographical boundaries. Typically, what we do is if we have clean boundaries between local authorities, such as two local authorities merging into a single one, then we can produce new results for them based on weighted proportions, similar to our other aggregation. So if two local authorities merge and one was twice the size of the other, then we would do a weighted aggregation where the new combined authority is 2/3 the score of one and 1/3 the score of the other. It gets a lot more complex in some very specific cases, such as BCP, Bournemouth, Christchurch and Poole, and Dorset had a complex split a few years ago where Dorset became its own unitary authority, but Christchurch, sorry if I'm remembering this not quite correct, but one part of Dorset had left what was previously known as Dorset and moved into this new Bournemouth, Christchurch, Poole one. In these cases, sometimes we can go to more granular data and estimate from the levels below unitary authority, but other times we have to do a proportional aggregation based on the population of the new area and the population of the old area. In each of these cases, for a start, I think my explanation there was a little bit rambly. There is a much clearer explanation in our methodology article, which I'll link to when these slides are shared. In a new year, we present all of our results for the past time series in that latest year's geographical boundaries. So if a new local authority has been produced, they will then have a back series based on these types of aggregations or estimations. In some cases, if we've had, the one other example I'll give on this one is if a local authority has split into smaller ones and there just isn't anything available at this new lower geography for previous years, they will all just share the results that the previous larger authority they split from had. So it's not perfect, but it does allow us to make some comparisons over time, even when a local authority is quite a new creation. And the same applies to integrated care services, where we've got results for 2020 for ICSs, but I don't believe ICSs actually existed yet in 2020. So what they mean as far as that ICS's performance probably isn't meaningful in that year, but they're produced using geographical boundaries and estimates of what proportion of population from each of their component LAs has gone into that ICS, which are produced by OHID. Sorry to say one more thing on this question. It's just the geographical boundaries. Clearly, it's on my mind at the moment. I said that this is quite a different question for Chris and Cara, and that's because we're able to do some of these and handle them in a more case-by-case basis because we're looking at 300 local authorities. LSOAs, there are so many more of them, and if we were to move to a nationally produced health index at LSOA level, we would need to come up with some other methodology for handling this, because these sorts of boundary changes I expect occur all the time in different local authorities within them, that is, in different years, and it just wouldn't be feasible to handle them on a case-by-case basis. So that's something that we'll still need to identify a solution for in the future if that's the kind of output we want to move towards.
That was great. Thank you so much, Greg. Another question from Jenny Sweetman. So are there plans to expand the health index to cover other UK devolved nations? I believe you did touch on that on one of your slides. But yeah, I don't know if you want to say anything further on that, Greg.
I can say a bit more. I was very glad Jenny asked that at the point she did, because it was just before my transition to talking about it, so it framed it well. I could say a bit about the progress we've had on that. We've got colleagues in Welsh Government and Public Health Wales who have conducted a comprehensive review of the indicators we use in the health index and what their equivalent would be. And that's a really good start for us thinking, what would it look like if we were to just expand the health index to England and Wales? Because so many, or compared to Scotland and Northern Ireland, Wales has data collection that's more similar to England. There are a few things that are collected together for the two. For example, births and deaths registrations are collated for England and Wales together by the ONS. So it gives us a bit of a stepping stone to work from compared to the other two nations whose data aren't quite as similar to England's. So they'll work quite nicely as a proof of concept, hopefully. Our team is also supporting a general push that ONS has received from wider government and members of the House of Lords especially, on making UK data more coherent and looking across a series of indicators to see which of these can we as government produce coherent UK statistics on. And my team is directly supporting that work. And some of that includes some modelling for if measures aren't identical between the nations, such as a hospital waiting time being measured from ambulance arriving at your house versus ambulance arriving at hospital or something similar. What modelling can we do to harmonise these into an actually comparable measure? Our work to support that wider government initiative is going to directly inform us what's possible and not to do the same with the health index. So there are things moving. I can't promise when we'll see outputs from them, but we very much have UK health index in mind.
That is fab. Thank you so much. So another question from Farhat Abbas. Can we select two-tier authorities in the very useful interactive map tool? So for example, Lancashire.
Not currently, sadly. And that's again for user simplicity. We don't expect many people in the public will fully understand the difference between upper tier and lower tier local authorities, and we worried it would muddy the tool to include both. So if, for example, you go to select your local area and there are two things that are very similarly named, such as Cambridge and Cambridgeshire, maybe it's a bad example, but people might not know for certain which one they need to select to find results that are most relevant to them. So we're looking at using that same sort of interactive tool for other geographies, particularly ICSs and custom geographies of someone's choice. So, for example, Greater Manchester consists of 10 LTLAs, but isn't in itself a region. But I expect a lot of people, including Greater Manchester councils themselves, would very much want to be able to see results at that level. And that's similar to the type of work that Chris and Cara have been doing of how do you benchmark to a level that's most meaningful to them, because those individual councils probably care more about a Greater Manchester score than they do about the England score when doing that sort of comparison. So it's something we've considered. It doesn't quite make sense just yet in our current outputs, but that doesn't mean it won't be possible in future. And at least for now, the actual numerical results for upper tier and lower tier local authorities are both presented in our data downloads.
That is great. So we have another question by Harvey Vicent. What technology did you use for analysis and display? Was it R, Python, or Shiny? So yeah.
I think Cara answered this indirectly when talking through our methodologies. Almost all of our code is in Python. Our outputs on the ONS website are in some bizarre language that no one's ever heard of. But I think the ONS data viz folks are keen to keep to themselves. But our new health projections tool was predominantly built in Python and GitLab, and it's now using a specific platform I can't remember the name of that's allows you to run an interface directly from GitLab. So I can provide that information more afterwards, but the simple answer is the vast majority of health index and projections work is done in Python.
Perfect. We've got a question from Nicholas Shelton. If new data is added, how will the index be comparable over time?
We're planning an approach that is similar to the RPI and CPI, the two retail and consumer prices indices, which ONS produces, where they create a time series, but it's based on the prices of a basket of goods. And that basket of goods can change over time, both in terms of the quantity of items within it and which items appear in it, which items are removed over time. And we're effectively trying to see health in the same way. We have 56 indicators in the health index. There may come a point in future where something we're not measuring right now, we can and want to measure, and we can add it to the index. In those cases, where possible, we add it and produce the back series and adjust the back series, so you can see how that has changed over time. But there may be cases where in future some aspect of health we measure becomes less important for whatever reason. Maybe there's a future where smoking prevalence becomes so low that it's not meaningful for us to include in the index, for example. In those cases, we are planning to lean quite heavily on our colleagues who work on RPI and CPI to understand how best they produce those changes to their basket of goods to maintain the back series. In general, we want to do our best, especially once the index is fully developed, to not revise our back series unless we have to, because that just makes it more easy for users to interpret. But that's our planned approach of seeing where we can get new data, how much of our back series can we add it in, can we revise with that data added and be able to show what the trajectory of it has been, so we can see a meaningful change over time. But there are some more complex examples of if an indicator remains in the index, but the source we're using to inform it is different, what does that mean? And again, that's very similar to some of the challenges that Chris and Cara have faced of whether an indicator is meaningful at LSOA level that we've been able to show at national level. And a lot of this, the answer is effectively some very hard work and critical review of which sources we can and can't use. And then a quality and value judgment of how statistically similar they are. Are they similar enough to count as the same indicator? Are they different enough that one indicator should leave the index and another one that measures a kind of similar thing but with a different name is added in? These are the types of questions we want to answer. But in general, once the index is fully developed, which we're hoping will be by its 2022 release, these types of larger methodological changes we're not planning on doing every year. We're planning on having a process whereby, say, every 5 years we do a more comprehensive review, and that way we can keep the time series stable for longer and therefore make it more useful to users.
Sounds good. There was just a few individuals that had kindly shared their emails who were interested in the tool. So I've made a note so I can share those emails with you afterwards, Greg, so after the session. So we had a question from Vicky Ryan. Can you say who the epidemiologist you mentioned at Newcastle Uni was who was involved in this projection modelling?
Yes, I can. It's been two. So one is Carol Jagger. She developed, oh no, I've forgotten its name, that's bad timing. She developed a very clever dynamic model for understanding multimorbidity. I think it's called PAXIM, and I really hope I'm not getting her model confused with someone else's. And she has informed the health projections and our methods for understanding what the time series might look like into the future, given the data that we have available. Carol has recently retired, And while she made every effort to stay on our group, even in her retired state, she has quite rightly decided that she has too many things she's doing to keep up with that now. So we have been working with her colleague, Andrew Kingston, who is still based in Newcastle Uni, has done a lot of the work with Carol, is similarly expert in these types of population health modelling questions. And both of them have been invaluable to the design of these tools.
That is great. I think Vicky knows both of them, which is fabulous. So, so we have two questions from Farhat Abbas. I'll start with the first one. So, are the indicators in the local health index same as those in the health index?
As much as possible, yes. So Chris was our data expert and knows the details, but we did have to make a few substitutions. So, and we also had to take some out to make some vaccination.
Yeah, there was a few where we just simply couldn't get our hands on the data. A few some underlying indicators for example, childhood vaccinations. So we were able to get MMR data. So we used the MMR data as kind of a, so I don't think of
Substitute.
That's the word, thank you. It was a substitute for some of the other vaccination data that we couldn't get hold of. And Greg mentioned the rough sleep account before. Obviously, that rough sleep account works great for local authority level, but when you've got, say, maybe 12, 14, or 15 rough sleepers in a local authority, they're all going to be clustered typically in one LSOA, usually around the town centre area, so it wouldn't really work for our other LSOA. So we didn't use that one, but where possible, it was very, very similar set of indicators.
Thank you so much. And then the second question was, so Farhat has said that she's sorry, she's being a bit cheeky, but are there any plans by ONS to extend the local health index to other areas in England? So using the Northumbria methodology, local health index looks very useful.
Hoping so.
A bit of a crap answer from me as representing ONS, but I'm hoping so too. It's something where we as ONS and I personally really love the work that Chris and Cara have done. I think it's such an excellent proof of concept for how well we can understand health in these local areas and how holistically we can view health in a way that we just haven't before. And the health index takes steps towards that, but the local health index just amplifies that sort of insight. We have colleagues in some other local authorities who have approached us and asked if they could similarly try to use the Northumbria methodology and test it for themselves. I believe that Suffolk County Council are aiming to do something similar, and there might be one other who I'm forgetting. Our overall aim with the business case that I believe Chris mentioned is that ONS and Northumbria will be able to advertise this health index methodology to other local authorities to either give them support with the expertise that Chris and Cara have developed from doing this work to achieve similar for their areas, or for between us as ONS and us as Northumbria to have a mixed model where for some, if we're provided the data or can give them advice on how to find suitable data, we could produce similar for them. So ideally, we would have some form of Python package or similar, which allows you to input data and you can produce your own local health index. There is an ONS ambition for us to have as I said, the UK level, more timely and more granular health index as a regular publication. But as I alluded to in some earlier questions, the production of LSOA level index at national scale might not be feasible. So what's possible there and not still needs some scoping.
Thank you so much. I think we've kind of come to the end, but I might just squeeze in one more question actually that I had for Chris and Cara. So my question really is, did you get a chance to test the tool with like the public? So how did they do with the interpretation, or is there any plans to kind of test this with people to kind of see if they really understand what's going on? You know, obviously us coming from an expert point of view, we could kind of get what this terminology and jargon means, but just to kind of see what the user's perspective is on this.
Yes, so we have tested this with a small group of, I'll say, members of the public, non-data people. So we presented this to our board of governors. So so these are our typically people, our service users. So these are members of the public who are, say, non-executive governors of the trust, and we presented it at the chairman's governors meetings. And it was quite well received. I mean, as you said, there are some challenges with understanding some of the terminology, understanding some of the geography and the data, but we think it's quite intuitive. I mean, the layout that LCP have built for us, it does work quite well. It's very accessible, and at least I don't think, based on the feedback we had, that anybody struggled with it at all.
No, I don't think it was, and I think the governors respectively took it out, and I think that might be how that GP that I mentioned in our case study got their hands on it. So they then went off and dispersed, because it is difficult as a two-man band, if you like, to get the word out there and spread the word. So yeah, we have been engaging with the Trust and Equalities Board and working closely with them, and like Chris said, going out and speaking to the governors and getting the chair of the trust on board as well, to sort of spread the word where we can. We haven't had, I don't think we've had any bad feedback.
That's brilliant. That's great. I'm not shocked. I'm sure it's been really, really great. But yeah, I think we can call the webinar to close. I don't know if there's anything else. I'm sorry if your question wasn't answered. I know there was probably a few still left in the chat. Maybe Greg, if we could kind of probably send round or get in contact later on and just answer your questions. I think there was 2 that we still didn't get time to answer. But yeah, don't want to like keep people longer than they need to stay on. But yeah, so thank you for your time, everyone. I hope you really enjoyed the webinar. Thank you to the speakers for their time. I think they deserve a round of applause. So it was really great. So thank you so much. And we will hopefully keep everyone updated and probably do a future webinar on this as things progress, because it would be really great to see the transition and how this kind of goes about in the future. So thank you for your time, everyone.
Thank you for having us.
Thank you.
Yep, thank you very much.